Good evening, everybody. We welcome you in Rehabilitation Science Group. Thanks to all the subscribers. With the good grace, the channel is coming with the national and international speakers. In the series today, we are having the Dr. Snehal Patel with us. She would be taking lectures on the paraplegic rehabilitation. Dr. Snehal Patel did her bachelor's in physiotherapy from Sikkim Manipal University, master's in physiotherapy in neurology from Parwana Medical College, Maharashtra. She is a certified NDTA basic and advanced trained from the NDTA. She has done her PNF from the International PNF Society of the level 1, level 2 and the 3A. She is the joint coordinator in the IAP Women's Cell of Maharashtra State. She is working in the Paraplegic Foundation of India. She is working in the Multiple Sclerosis Society of India in Mumbai, along with the Neurology Foundation, Mumbai. Dr. Snehal has received a lot of national and international awards, and she has got the numerous publications in her name. Thank you, Dr. Snehal, for giving time for us.
Thank you, sir. So, good evening, all of you. It's my privilege to explain in this lockdown period about the session on the rehabilitation of paraplegic. So, I would like thanks to Dr. Shagun Agrawal sir, Dharam sir, and Harpreet sir. So, giving me opportunity to talk on this. So, as yesterday, Dr. Dikshit, he already explained some of the basic ideas. So today I will be go on basic how to do rehabilitation, basic rehabilitation on paraplegic patient. Sir, I will share my screen.
Yes. No, we can see your screen.
No, I can't see. I can't see. Wait. Okay, it's visible?
Yeah.
Okay, so today we'll speak about physiotherapy rehabilitation of paraplegic. So starting with the definitions, what is the spinal cord injury? So spinal cord injury, it is a low incidence with a high cost disability requiring the tremendous change in the individual lifestyle. So if you see on the pictures, there is a cervical, thoracic, lumbar and sacral coccygeal of the whole the spinal cord. So if it is injury to the cervical can lead to the quadriplegia. So there is a loss of control of the bladder and bowel sensation, loss of sensation and motor control of the upper extremity along with the lower extremity. And there is an injury to the cervical injury. What is the paraplegia? Paraplegia is the simple definition. There is a loss of sensation of lower extremity along with the motor control with the bladder and bowel sensation. Our hands, the upper limb will be intact. There is a loss of trunk control also. So there is an injury, either higher thoracic injury or the lower thoracic injury or the lumbar injury, depending upon the level of region. So today we'll be mainly dealing with the paraplegic, not dealing with the quadriplegia. So next will be, so there are the classification of cause of paraplegic. So what are the different classification? So either congenital or developmental. So some of the congenital developmental like the spina bifida, or there is any inflammatory or infective, there is a pot spine. Majority of cases can see as a pot spine at a different level, or there is a neoplasm, tumor in the spinal cord region, either malignant or benign in the different lesion. degenerative or demyelinating disease. Some of this, like the thoracic or the lumbar, age-related changes can be seen, can reach to the spinal cord injury at very severe level, or either traumatic. So majority, the motor vehicular accidents are the one of the cause of the disability with the paraplegia, either with the intracranial and also the vascular. So as I already explained, the motor vehicular accidents. So if you see nowadays, the people, I can see majority of patients where I observe, like the four-wheeler when they are traveling outside without taking the belt or the helmet, or the two-wheelers not wearing any helmet. Because of that, there is an injury to the spinal cord injury, which is most devastating and can lead to the permanent disability. So I would rather give the suggestions to all the youngsters also that use a belt and use of the helmet when you are driving. So because majority of population are because of MVAs occur, there is a fall. So some of the labor works during the construction site, there is a fall. Some of the having the history of the fall from the height during construction site, or there is a during the rainy season, the fall of the wall, there is a wall crack in the house also. So these are the common things where during the history we are thinking that why this is important to ask this history, what is the causes of the injury. Next will be gunshot injury, the blunt assault or the diving accident also. Then stab wound injury and some of the sports injury like the basketball or the football, many other time because of the injury so difficult, they will cause the either paraplegic or the quadriplegia also. So during history taking, you have to ask which type of the job is that, what occupation is there, and how the injuries occur. The mechanism of injury is also very important. So this is the relationship between a spinal cord and the nerve root to the vertebral bodies. So if you see, this is a basic idea for all the students, where you can see there is the blue color, there is a cervical, there is a red color, there is a thoracic, the green color is the lumbar level, phi lumbar, and this is the sacral. Okay, so which is supplied to the C1 to C8, there are different on the depending upon the each levels. C1 to C4 is controlling the breathing, C1 to C3 head and neck control, C4 to C6 heart rate, C5 shoulder, C6, C7 wrist and the elbow, C7 tricep muscle, C7 and C8 finger, T1 will be hand. So if you go through the red mark, so now it's come exactly what we are looking for, the T1 to T12. T1 will be the fan muscles, T1 to T12, there is a temperature regulation, there is a sympathetic tone and truncal stability. T7 to L1, there is abdominal muscles, and 11 to L2 is the ejaculations, and the L2 hip muscles, L3 quadriceps, L4 and L5 hamstring and the knee muscles, L4 to S1 foot and the knee flexion, S2, S4 there is a perineal erection, spinal erection, and S3, S4, S2 and S3 there is a bladder and bowel control. So these are the important to understand the basic relationship between the which dermatome and which myotomes will be work and what is the important of that. So on the green box you can see the vertebral level and spinal level. So if it is very important. If the injury is at the any cervical injury C4 to C7, you have to add +1 to checking the spinal level. So example, there is a T1 to T6, there is a +2 vertebra. T7 to T9 +3 vertebra. T10 to L1 to L2. T11 correspond to L3 and L4. And T12 will be L5. Below L1, there is a quada equina. So if I give you one example, if it is an injury to the T8 level, what is the spinal level? If it is the vertebral level is a T8, what will be the spinal level? Can you give me the answer? Hello? Hello? So if injury is as a T8 level, the spinal level will be +3. So you have to add +3 on the T8. So T11 will be your spinal level. Okay. The next will be, these are the dermatome. So these are the area of the skin innervated by the sensory axons within the particular segmental nerve root. So example, there is a, you can see on the chart on the anterior aspects, this is a C2, C3, C4, there is a neck area, C5. T4 will be at the nipple level, C5. Then this, if you go on the arm side, there is a C5 on the outer side, C6 will be on the thumb, C7 to C8 little finger, T1 on the medial border of the arm. So same way you can go through the lower limb. If you see this photograph, L1 at the ASIS, then comes to the L2, L3, L4. L4, okay, towards the going to the medial aspects, L5 on the lateral aspect, S1, there is a going to little toe. So for doing this, when you are dealing with the spinal cord injury, you must be thorough with the dermatome levels and also the myotomes levels. So the myotome will be the segmental nerve root innervating the muscles. So what is the upper limb muscles for the C5? C5 deltoid, C6 wrist extensor, C7 elbow extensors, C8 long finger flexors, T1 will be small muscles of the hand. Okay. And the lower limb will be L2 hip flexors, L3 knee extensors, as the quadriceps, L4 ankle dorsiflexors, L5 long toe extensors, S1 ankle plantar flexors. So you should have the thorough with the dermatome and the myotome levels of the body. So this will help you to coming up with the next part, that is the Asia scale. So those who attended yesterday class can see majority, Dr. Dixit has already explained the Asia scale. Today I will give you 2 mock tests so to rule out how you understand this scale or not. So basic idea I will give, this is the motor and sensory component. So motor, we will same, I already explained C5 to T1, you have to do additional, there is a 25 marks, total will be 50 grade. Then the lower limb, there is L2 to S1, you have to see the manual muscle testing 1, 2, 3, 4 or 5 grade. According to that, the total score will be, you can add on this down level. Same way, there is a sensory, you have to check the light touch and pinprick. So 0 will be absent, 1 will be impaired and 2 will be normal. So you have to go through C2. If it is a 1 or 2 or 0, depending upon, you have to check the each and every dermatome like this with the light touch and pinprick. Okay, with the use of safety pin also. So this basic things I will not explain, and you have to do the addition of the total scoring. There is a 56 and this is also 56. So pinprick will be total maximum will be 112 and the light touch will be 112. These are the key muscles. Next will be here to see the voluntary and the anal contraction is present or no. And the anal sensation will be yes or no. You have to check with the anal sensation and anal contraction. Some of the time it will be done under the neurologist also. So you have to see and to be very careful with this sensation and the motor control. Next will be you see the neurological level. So after finding this, you have to put right and left side, which is the neurological level on the both the side, complete or incomplete injury. So now this is the Asia scale. This is a mainly scale used for the recovery, how much patient is recover and what is the progression of the disease. So Asia A will be complete injury. There is a no motor or no sensory function is preserved in the sacral segment S4 and S5. B will be incomplete. So what is incomplete? There is sensory is present, but not motor function is preserved below the neurological level, including sacral segment S4 and S5. C will be incomplete. Motor is preserved below the neurological level and more than half of the key muscle, if you see the upper limb and lower limb, The neurological level have grade less than 3. D will be incomplete. The motor function is preserved below the neurological level and at least half of the key muscles have the grade 3 or more. E will be normal. Motor and sensory both are normal. So now we can see this is one of the thing. If you can see in this box, motor level for left side, on the left side, C5 will be 5, grade is 5, and C6 will be 3. So what is the motor level on the left side will be C6. Okay, this is the most motor level where the distal segment of the nerve root will be intact. The muscle grade will be the normal. And at the right side will be C7, because C5 and C6 will be grade 5, it is a full, C7 will be 3. Below C7, it is a 0 and 0. So overall level, overall motor level will be both the things on the left and right side where the muscle, where the grading will be distal will be equal to both. So common will be, both the common will be 3. Okay, at a C6 level, both are intact. So most distal segment or most caudal segment where the motor function is preserved, there is a C6 level. Now coming to this, if cannot test the motor level, then motor will be same as that of sensory level. Because some of the, in 1996 of the, some of the research is done that the from T2 to, if you can see on the motor level, T2 to L1, we can't check the muscle strength. So in this example, if here motor is T1, the finger abductor is 5 and 5, upper limb is 5. If you check on the sensory part, T8 will be 2, both the left and right side. So here the sensory level will be T8. So sensory level and the motor level will be same. So motor level is equal to the sensory level will be T8. And as there is a no anal sensation, no anal sensation and no anal contraction, will be complete injury at the T8 level. So this is a basic idea where there is a motor is equal to the sensory level. Now coming to this is the case 1. You just observe, I give you some time. You have to tell me motor level, you have to tell me left side and right side, sensory level, left side and right side, neurological level, Asia which grade, A, B, C, D or E. You have to tell me either complete or incomplete. Okay, just go through and tell me which is the motor and sensory. So if you see first on the, I'll give you the answer, sensory. Right side is a T12 and the left side is a T11. Okay, I'll go through the again. Sensory right side T11. If you see on the right side, if you can see here my cursor, right side will be 2 grade. Here is also a 2 grade. Okay, and left is a T11. Now coming to the motor, here is showing the T1 and this is 5 grade, this is also 5 grade. But what we already explained, the sensory level will be same as that of the motor level, same as the sensory level. So here is also same, motor will be on the right side T12 and on the left side will be T11. So neurological level will be most distal segment where the intact. So last distal segment will be T11. And why it is a complete? Because it's written there is a no anal sensation and no anal contraction. Both the side there is a no and no. So it is a complete injury T11 injury, Asia grade A. Okay. Any doubts, you can put it on the chat box also. The next case will be, this is the case. You can go through, I will give you answer in a short while. Same way you have to tell me neurological level, motor, sensory, right and left side, complete or incomplete, and grade A, B, C, D or E. So for this, on the sensory, if you see, the most distal segment with the normal sensation on the left side will be at the L2. Okay, and on the right side will be L1. Now we'll just check. Okay, so sensory on the right side L1 and on the left side it is a L2. So motor will be at L1 same, and the left side is L1. So neurological level will be same, is a L1 level. This is the most distal segment where the both sensation and the motor will be at normal. So this is the L1 level. And it is incomplete. Why it is incomplete? Because it's written there is a voluntary anal contraction is not present, but there is a presence of anal sensation. Okay, so it is the sensory is present. If you can go through all this chart, the sensory is present but not motor function. So according to this, Asia grading will be B. So this will be case is a incomplete injury L1 Asia B. Now coming to, okay, this is the chart I can give you at the end of the presentation. If you want to check yourself that how much you understood this case, there are demonstration or the mock test will be available. So you can check the online also. So the effects of complete transaction, they are occurring in a 3-stage. So first stage is a stage of spinal shock. It is a refer as a temporary loss or a depression of spinal reflex activity that occurs below a complete or incomplete spinal cord injury. And the stage of reflex activity, there is a phase of recovery. And third will be stage of reflex failure. So stage of spinal shock, there is a duration is about 2 weeks. So acute effect will be occurs immediately after the injury and transaction, and severity affects the based on the site of injury and severity of trauma. So this will be immediately after the injury, there is occurs till the 2 weeks of injury. So spinal shock characteristic, there is a loss of muscle tone, complete flaccidity of the paralyzed muscles below the level of injury, paralyzed of bladder, rectum and flaccid penis, loss of all sensation below the level of injury. There is a sharp fall in blood pressure due to lack of sympathetic innervation, loss of almost all the somatic and the visceral reflexes, and skin is become very cold, pale, and the scaly and the dry. So this is mainly because of loss of muscle tone, paralyzed bladder and rectum. The second will be stage of reflex activity. There is a complete transaction of the cord. It is occur after the 3 to 6 weeks of the individual, with the variation always occur. It is also called either stage of recovery. During this stage, there is a reflex activity. There is a muscle tone is start developing, and the skeletal muscle and mass reflex begins to appear slowly in a phased manner. Initially in the spinal shock, there is a no tone. Now slowly muscle tone is start developing. The reflex activity, there is a smooth muscle activities appears firstly, and gradually there is a defecation reflex and a maturation reflex will be established. After the some time, there is a sympathetic tone of the blood vessels restored due to activity of spinal nerve and leading to restoration of blood pressure and sweating mechanism. So slowly tone is generated and body comes to the normal temperature and normal way. So skin is become now healthy. The recovery of muscle tone first is appear in a flexor, then the extensor, and leading to the more flexion of limb make the individuals to support the weight of the body. After the 4 weeks, the tone of the extensor will be appear and a mass reflex appears and used by the patient to provide a better bladder and bowel control. The last stage will be stage of reflex failure. In this, the reflexes become very difficult to elicit. That is always stagnant. So increased threshold for the stimulus, there is a loss of mass reflex and flaccid muscles undergoing wasting. Hypercalcium and hypercalculia leading to the formation of renal stones, and there is a chances of infection, septicemia and the uremia. So these are the transaction of the spinal cord. If you see, there's a posterior column and the anterior. So the anteriorly mainly spinothalamic tract and the lateral corticospinal tract, which is for the muscle tone, spinothalamic tract for the pain and temperature, and posterior column for the proprioception and vibration. So these basic things here to at least understand. So this is the cervical, most center, then thoracic and lumbar and the sacral area. So why this is important? Because during this there is a different cord injury or the different cord syndrome depending upon the how the injury to spinal cord. If the patients complain मैं ऐसे गिर गया, आगे जाके ऐसे गिर गया, so there is a flexion injury. So sudden flexion or the rotation to the cervical injury, so damage to the, if you see the red area, so damage to the corticospinal tract, the laterally, and also the pain, there is a spinothalamic tract will be damaged, but dorsal column, the posterior column will be intact. So there is a loss of motor function, pain and temperature sensation will be lost. The vibration, position and crude touch will be maintained. So that is important. You have to ask the patient during history taking what is the mechanism of injury. So accordingly, through your assessment, you can check with your assessments of sensory and motor which tracts or which fibers are intact or damaged. Now posterior cord syndrome, there is due to hyperextension injury. So patient will be fall directly backward to, there is a damage to the posterior elements of the vertebra. So on this reed portion will be completely damaged. So there is a preservation of motor function, some of the motor function and pain and light touch. There is a loss of proprioception, vibration. So wide base steppage gait pattern, there is ataxia. The typical pattern will be seen. Central cord syndrome. So there is a hyperextension injury to cervical region. So motor weakness will be more present in the upper limb. Why? Because if you see on this area, the cervical, this is the area, the cervical and the upper limb will be more involved in the central portion. So motor weakness more present in upper limb than the lower limb. There is a loss of pain and temperature sensation than the proprioception. This will be intact majority. If you see, the burning sensation is present in the patient feeling in the upper limb part and commonly seen in the older individual where there is a cervical arthritis, degenerative changes in the narrowing of spinal cord. Coming to this, there is a Brown-Sequard syndrome. So there is a hemisection of spinal cord either due to penetration injury or some of the gunshot injury or some of the bullet injury or a fracture. There is a lateral fracture of the lateral masses of vertebra. So paralysis on the affected side. There is a corticospinal tract will be damaged. There is a loss of proprioception and fine discrimination is occur in the dorsal column. Pain and temperature losses occur in the opposite side below the level of lesion. There is a spinothalamic tract because of their crossing the fibers. So same side there is the posterior column damage. On the opposite side there is a loss of pain and temperature. So cauda equina injury will be majority, if you will see during the coming video. There are mainly peripheral nerve injury to the lumbar and the sacral and coccygeal nerve roots. Symptoms may be motor and sensory losses in the lower extremity, patient with the sciatic pains and the bladder and bowel dysfunction majority, and the saddle anesthesia. These are the basic differences between UM and the element type of lesion. So either the location of lesion, either CNS, cortex, brainstem, corticospinal tract, and in the element there is a cranial nerve nuclei, anterior horn cell, and the spinal roots. Tone will be in UMN will be increase in the tone, spasticities appear. In element there is a reduced tones, hypotonicity. Reflexes are the deep tendon reflexes are hyperreflexia, and the clonus will be present. There is involuntary contraction and positive Babinski sign. In the element type there is a hyporeflexia or absent of reflexes. Involuntary movement, either flexors or extensor spasm. So majority there is a involuntary contraction, either limb into completely into the flexion, like the lower limb into complete flexion attitude, or completely in extension pattern because of the flexor or extensor pattern. And there is in the element there is a fasciculation presence. On the UMN there is a disuse atrophy. In the element there is a severe wasting of the muscles. So these are the general basic ideas, the difference between UM and the element type of injury. Sometimes if you see the practical aspect, when the patients comes to paraplegia, sometimes it's not correlate with the what are the findings, which is we really see in the theoretical part. So on the practical aspect, we have to see like what is the reflex, how is the deep tendon reflex, what is the muscle tone. Either it is a higher level of injury or the lower level of injury. Initially might be the tone will be less, and slowly it start developing. So these are the basic complications if you see in spinal cord injury and paraplegic, like the autonomic dysreflexia. So lesion will be occurs above the T6 level. There is a change in the blood temperature and the blood pressure regulation. So this is very important to take care of this autonomic dysreflexia. Respiratory complications, pressure sore. Most important issue will be all the paraplegic. They don't have the sensation. So they start developing the bed sore on the sacral and the buttocks area. So frequent change in the positions will be very much important with the proper diet. So for the pressure, so you can grade the one of the scales. So you can check with the treatment, like if you are giving any UVR or any other dressing you are giving, there is a pressure ulcer scale for healing that you can use as a one of the outcome to see the how much is the bed sore is healing. You have to explain to the caretaker also to check the skin area if there any problem, or with the when you are wearing the orthoses, that time also there is a breakdown of skins. Majority of the in a lower socioeconomic side, the patient will be using for the food, like the during lunch and the dinner time they are using the hot plate and keeping on the lap. So because of they don't have sensation, majority of time they are start of developing bed sore and the skin breakdown is occur. So you have to take care of the all the take things precautions. Pulmonary embolism, deep vein thrombosis. To for this to prevent, to give the proper ankle stocking, you have to give passive limb motion exercises, you have to give, and the limb into the elevation position. Postural hypotension, because of the acute phase, the patients are in the supine position completely. When they change the position, there is a change in the blood pressure will be lower. So from supine to the erect sitting position or erect standing position, there is a blood pressure will be fall. So for this, you have to do the certain exercises to in a controlled manner. You can use some of the tilt table exercise also. Edema, the like this ankle swelling is most common issue. So to maintain the majority of time, the patient is sit for a quite long time in the wheelchair also. So for that, you have to prevent this by using the supported weight bearing position of the lower limb also, and you can use a pillow. Pain. So pain, either dysesthesia or the severe pain, neuropathic pain is occur because of the certain nerve tracts and nerve fibers which is coming to the spinal cord. So most of the common time, this pain can be very much issue to the patients, can be treated with the use of ice pack or some of the analgesics. Heterotrophic ossification, there is mainly the calcium deposition in the majority like hip joint and the knee joint and the elbow joint. Because of that, some of the movement are restricted. So initially level you have to give the ankle range of motion exercise, hip joint exercise and the knee joint exercise. So in the coming to this, we will see one of the video where the patient is having heterotrophic ossification on the both the like the elbow and the hip joint. Because of this, how much trouble he is facing during rehabilitation aspect. Contractures, the mainly the tightness and some of the deformities are also developing like hip contracture, hip muscles contractures, osteoporosis, the weak bone. So you have to give on a proper diet, some of the calcium medications under supervision of your neurophysician and along with your team. So the osteoporosis can be prevented with the give the some of the weight bearing exercise on the tilt table also. So these are the major complications that you have to manage. So management. So its management is by the teamwork. So teamwork will be by the neurologist, neurophysician, physiotherapist, occupational therapist, the counselor, psychologist, patients, and the caretaker is very much important. Dietitian. First aid importance, general care, personal hygiene, how to, these are the general instruction you have to tell to the patient and caregiver. Personal hygiene during the acute phase with the sponging, bath, and the appearance and proper diet, proper nutrition intake, taking a proper water intake will be very much important. This will prevent the urine infection also. The care of skin to prevent and to treat the bed sore also. So bed sore is the most important thing. So you have to frequent change of position every 2 hourly, use of air bed and the water bed, and to proper diet. So you can give healthy diet as a egg also. The egg which also contain high protein, so that will give more healing, will be faster of the bed sore. The care of the skin, they can also check with the mirror. So physiotherapy management in intensive care, like the positioning, respiratory care, skin care to maintain ROM and resting splint. So in PT management in intensive care, till the patient become medically, surgically stabilized, remain in ICU. So goal of treatment will be establish communication with the patients to improve and maintain a good respiratory status, maintain range of motion and strength of the spare muscles, maintain the skin integrity and educate the patient and family members. Respiratory management will be postural drainage, breathing exercise, percussion, assisted cuffing, chest mobility, posture, abdominal binders to support the diaphragm in a functional position. So positioning and ROM, there is a proper position to prevent skin breakdown and to minimize a contracture like the twice a day. ROM exercise for all the extremity, full and extreme range will be avoided. Mainly prone position will be good to prevent hip flexion contractures. Initial level with the paraplegic lesion like the lower thoracic injury, full SRR will be not given. Ankle dorsiflexion should be at least of 90 degree. Splinting should be used to prevent the tightness. So important aspect now coming to strengthening exercise, the upper extremity strengthening is very much important because they have the only this muscle which is the spare. So we have to make sure that this muscle will be very strong. So they can use in the further for the rehabilitation, for the transfer, for wheelchair skills and for the functional activity. So strengthening can be used with the weight cuff, the other therabands with the individual joint. Scapular exercise, latissimus dorsi strengthening, quadratus lumborum activations. Group exercise for this strengthening is also part of strengthening. So group exercise can be with the help of weight cuff or the theraband exercise you can take with the same level of injury or either with the paraplegic or the quadriplegic, depending upon how you are taking the group session. So coming to next, these are the consent has been taken from all the patients in the following videos for demonstration purpose. Please do not copy or share this video. This is for the study purpose. So this is the patients with the complete injury at the T8 level. If you see, how to do the coming in the long sitting position. So let's dorsi strengthening. She's using the Taylor's brace. Okay. So coming forward and going to the backward. Use of all the strength of the triceps and the shoulder and lats dorsi strengthening. She's a complete case. So coming to this, activations of the quadratus lumborum. Okay, so in this activation, the wooden blocks will be front on the one side and hip hiking on the opposite side. If she is taking right hip in the front, the left wooden blocks in the front. So opposite manner. So it will be used for all the side flexors of the trunk will be, which is most important during standing and the other activity. So activation of QL is very much important. So coming forward and going to backward. So we have to work on the individual group of muscle, which is paired. So coming to the mat activity, so first is a rolling is an important activity. So rolling will be most important. Why? Because it's a first phase to come to the side position. So this will give help in the lower extremity dressing activity to change the position to prevent the bed sore. So rolling, we can use the momentum force of your hand. So although first we have to teach all the strengthening aspects. So use of rolling as a, you can use as a upper limb force momentum like a 1, 2 and 3 turn to the one side. So patient will be used where the neck is into the flexion, the scapula and the pelvis into the protraction position and turn the body to the one side. Initial phase, you can use the pillow to give more help to more assistance with the less muscle work. So pillow can be placed below the pelvis also and to the scapula, and therapist will give assistance with the hands, will be placed hands on the pelvis and or the scapula and turn to the one side. So rolling accompanied by the either crossing the legs, either in the straight position or with the knee bending. Patient who are having spasticity can cross the leg or the knees will be folded. Those who are the tone will be hypotonia, will be straight the leg. They can cross the leg. So these are the one of the device that is a leg lifter. It is called the leg lifter, can be used. The patient can, with the help of these devices, can be crossed and turn the body to the one side. It will be strap at the side of the ankle. If you can see on the photograph, it's like this. One with the, it will be available in the market with the wooden the rod also, the iron rod also. With this you can make as a homemade or the tailor made also. So rolling is most important aspect. So supine to sideline with the cross and uncross and the river, and sideline to long sitting position. So sideline to long sitting position is very much important because long sitting you can give more of truncal exercise and there is a stretch of the hamstring muscles and give more of the trunk control exercise. You can give the perturbations within the base and out of the base, like the recharge. You can give some of the boxing exercise as you give in the long sitting position, can also give some of the trunk rotations to pick up the object in the different direction can be given. Sideline to long sitting position. So coming through from supine to long sitting also with the help of on the both the elbows, like both the elbows are supported on the floor. So there is activation of the core muscles, abdominal muscles, and on work on your neck muscles also. Supine to prone positions and the prone to elbow. If you can see in this photograph, prone on the elbows and prone on the hands progression. Prone on the elbows, there is a shoulder and the elbow should be 90 degrees. So you can give in this directions. Prone on the elbow, there is a weight shifts front, forward and backward, sideway weight shifts. So there is an extension of the upper back also. There is a working on the serratus anterior muscles. Coming to the prone on hands, there is a more approximation, more joint approximation is occur. There is, you can see, there is hyperextension of the hyperextension of the spine, lower back muscles. So you can give some of the activity like the reach outs with the one hand within the base, nearer than at the far level, at the side level, or you can pick up the any object also. So prone on elbows to prone on hand, you can do push-ups activity, which is very much important for the next phase. After the prone on hands will be occur, there is a quadruped position. This quadruped position is very much important. You can do core activation muscles, reach outs activity. Then also the all four position will be give more weight bearing on the all the joints and prevent the osteoporosis also. From coming to quadruped, there is a crawling. So he is a case with the complete injury. So there is a in the crawling, there is a as there is a no sensation and the motor power in the lower limb muscles below the level of injury, so automatically with the help of the other muscles, use of upper limb and the spine muscle, there is a quadratus lumborum, hip piker muscle, he is able to move the body in the front. So like the 4-point pattern, like the alternate arm and the leg pattern. So right leg and the left hand and the right leg, alternate pattern, he is moving and able to shift the weights on the both the side. So this give more approximations and the more weight bearing. Some of the tasks you can give as a functional in the crawling, like the cleaning the floor or cleaning the mat. This is also the fine activity, important activity where patient can learn also when they are discharged at home. So coming to quadruped to kneeling position, you can use of the either the chair support or the ball support or use of the rail also. So this is a kneeling position will be give for the require for the when you are using the training like with the elbow crutch. So this is a pre-training for the use of the elbow crutch. There is a kneeling. So you can give same activity, core activation, reach outs within base and out of the base of support, some of the perturbation exercise. You can give the upper limb strengthening program in the kneeling position with the assistant. Some of the, if the patients are very hefty and it's very difficult, so can use the transfer belt for the use of the gait training. So this is a quad equina patients with the how to do the half kneeling to standing position. So coming to half kneeling, so use of the all the knee muscles, only the ankle is the issue in this patient. The knee is quite good. He developed good strength in the knee, but the ankle is still 0. So from half kneeling, alternative like the right leg in the front and the left leg in the front and the reverse direction. So this give the good feedbacks when the patient is goes to the home. Not every patient will be achieve to the till position depending upon the incomplete or complete injury, level of injury. That is most important aspect that we can check on the Asia scale. So important aspect how to do doning and doping of HKFO. Patient with high thoracic injury can use the hip, knee, ankle, foot orthosis with pelvic belt. T1 levels and the lower thoracic level, you can use knee, ankle, foot orthosis. Below this, lower injury, lumbar region can use ankle, foot orthosis. So this is very difficult part, doning and doping of orthosis, like you can see in this video. Wearing with this girl, very young girl with a complete injury, because of the weight of the orthosis too much, we need two helper to shift either in the sideline position. This video is on the sideline we are making to wear this HKFO. It's very difficult for her also because of the weight, and already you can see she is a very thin build. So wearing the straps and other things, now she is turning to one side. If you can see, she is using the both the hands. And now removing the one leg after the other with the help of assistant, because she is not able to do, we have to assist. So this is from sideline to supine position. Now this is the from the long sitting position, how to wear and remove the orthoses. So directly from long sitting, we have to lift the patient and put it in the orthoses. But we need the manpower also. So we have to always teach to the caretaker also, and always observe how they are doing properly or not, because the spinal cord injury or the paraplegic is difficult to handle and also need more take care. This is doning and doping of the KFO. So why this is long sitting is important, I told, because of this patient can use his power to wear the socks and also use of this device is independently. He doesn't require any help as he already learned. So this is the ankle strap. This is the knees support. Then the upper is a thigh strap. So he is strapping with his own way and managing by himself. This is also need a time. This is also one activity where using the all the trunk muscles, upper limb muscles, everything. Some patient is not reached to the ankle level, so we have to help them out. And you have to always careful with all the mat activities, care of the urine bag and the catheters. Majority of time it will be leak off or it will be come out of the area, so it will be very important. And before you start with any training, please empty this urine bag. Now he is wearing the shoes also for coming to the standing position. So gait training is very much important for all the patients. So gait training is required mainly with the jackknifing. So jackknifing, it's basically there is a sudden flexion of the trunk to the coming to the extension of trunk. So majority all the paraplegic will be stand on the Y ligament of Bigelow. That is a hip joint strongest ligament. So they will stand like a hyperextension of the spine. So this is most important part where they have to learn how to do jackknifing. This is the patients with the high thoracic injury. Standing, you have to start with the in the parallel bar first. So you have to teach to how to stand up with the help of the caretaker, with the therapist assistance, with the transfer belt. If you are not able to lift the properly, you can use the belt around the waist area also. And you do standing activity like the forward and backward weight bearing, reach outs, trunk rotation, stepping in the front, stepping backward and stepping sideways. So this is a high thoracic injury. With this patient T4 level, there is also he is having right elbow and the hip joint heterotrophic ossification. He's walking. We start him walking with the HKFO with pelvic belt. Initial wear is very difficult. The also we made the tailor made like the walker also, which is the iron one, not like the regular one. With the help of the one of the therapist also, initially it will be sliding the legs, then slowly you have to lift the leg as the depending upon the patient's fatigue level, because this is most fatigue level activity, like using holding the walker also, weight of the orthoses also, and moving the body in the front. Check the blood pressure, all the vitals before and after the treatment. So initially you start with the 6 to 7 steps, slowly progress, you increase the distance also. So he's the guy with the complete injury walking with KFO independently. So you can see only the mother is standing behind for the just for the help, but otherwise he is managed with the own. So if you feel the patient is recovery, you can discard from HKFO to the KFO depending upon the how the strength is developing and how the injury is coming up, like the complete or is there any muscle strength is improving or not. She's an incomplete injury. Now she's a very good. Now she's working in the office without any cane or devices. She's recovering very good in a way. She's using the cane as one of the device. If you observe the gait pattern also. So strengthening of the upper limb is very much important. Stair climbing. So next part will be stair climbing is very much important. So shifting the weight to one side and lift the pelvis in the front and see, if you see this, the lift the pelvis front and move, keeping the leg in the one step ahead, then same way with the other level. So use of the step, which is the lower height. So this is the quadratus QL's activation. The hip hiker muscle is very much important for this stair activities. So obstacle walking, some of the patients which is important who are incomplete injury, because after the discharge, these are the functional activities required when they go out. So you can use the bigger equipment also. We use the smaller one. He recovers with the only issue with the only the right ankle. There is a no grade. So we give only one side ankle foot orthosis with single elbow crutch. Initially he was on the double elbow crutch. So if you see, there is a more weight bearing on the picking up object on the opposite side with the crutch is where which hand the elbow crutch is holding. So working on the all the knee muscles, group of muscles, knee muscles, and also the core muscles. Okay, this will give more confidence with the other activities also. So this you have to plan according to tailor made. So which is important for the further rehabilitation. So this is the important, or not all the patients can go the wheelchair, getting up from wheelchair with the elbow crutch. There are the difficult, only very few can achieve. So this is the, with the help of two elbow crutch. With the two elbow crutch, first always this is very critical, holding, I'm holding the pelvis. Patient is using one elbow crutch and the other elbow crutch on the side of the wheelchair. If you can see here, on the side of the elbow crutch, then giving weight on the armrest and coming to standing position with the help of single crutch. And now he is taking the other crutch. If you can see in this photograph also, there are different steps is written. Now coming to reverse position, just maintain this position. This need more confidence. See, one hand on the armrest, one hand on the elbow crutch. The other alternative method is getting up from wheelchair with the elbow crutch. Only with, he will twist the body into the prone position. Like from the front, he will go directly to the back position. So see the all the scapula, all the upper limb muscles, the weight of the orthosis, how much endurance he is having, that is most important. Now he is taking one elbow crutch. Then after adjusting to the his own convenience, he is lifting the other elbow crutch. Now coming to same in the reverse direction, coming to sitting position. He is discarding the elbow crutch. Okay. Now keeping on the side of the wheelchair. Now from this position, he will come to twist the body. So this is the last aspect, that is a transfer training. So because of all this important, patient has to learn how to do transfer on the wheelchair. So I will just brief about transfer training to surface, one surface to the other with the help of any devices like the transfer board or like the wooden board. This is a transfer board you can use for the transfer training. Initially you give this and slowly you discard this, either from bed to wheelchair or wheelchair to floor, or from the wheelchair to car transfer, wheelchair to bike transfer. So these are transfer important whenever they go out. So these are the group sessions where we took for the different transfer training with the different level of injury. He is a complete case, one with the stripe. So in this video, there are mixed diagnosis. On this side, on the black, he is a pot spine cases with the severe spasticity at T4 level. If you see, some of the transfer can be used first, either lower limb first, then the pelvis first. This blue guy used for the backward transfer. So backward transfer is also important at the initial level. If the patient is very hefty and it's difficulty to shift, you can do backward transfer. This guy, you can see on this third, he's not using any devices because he trained. So we are not giving any devices. But the behind guy, we are giving the devices because still he's not that or confidence to handle. Now this person first using the pelvis first and the leg. Okay, and vice versa can be also do. So you have to teach to the patient as a group exercise is also important for give more confidence, more feedback. After seeing to the other patient, they also learn. And it's not, they feel not socially depressed also. So these are the summary where we covered SCI causes, Asia scale complication, management in ICU, mat activity, gait training, and transfer training. These are the references. So, and these are the down 3 links as a eLearn, SCI.org, www.physiotherapyexercise.com. In that you can see all the different level of injury. If you type example T6 level, what kind of exercise you will prescribe to the patient, everything you can take and you can save as online also, and you can tell to the patient also. And this last algorithm for the Asia mock test. I would like to thank Dr. Uttara Mohan, my colleague, my students, my patients, and caretaker. Thank you so much.
Thank you, Dr. Snehal, for such a wonderful presentation. And Dr. Harpreet is with us, and if he has any questions, and you can answer.
Yeah, Dr.
Harpreet, please.
Snehal, good evening.
Good evening, sir.
Yeah, it was a very elaborate description of spinal cord injury rehabilitation with demonstration of how patients are actually performing the transfers. And I think most of us have gained a lot from how we can work in a low resource setting. So your setting did not have much of treadmill, robotics, but still you could manage the basic functions and transfers with your patients. So what I feel is that in a country like India, it is very important that how you manage your patients with low resources in their societies and in their communities. And that's what you have shown to be of extreme importance. There were just a few questions that we wanted to ask, like how or is energy expenditure a factor in such patients? Like, how do you plan to conserve energy because of the hot climate in India and exerting physical activity?
Yeah. So basically, where I work, so majority time rehabilitation is a vigorous, like the morning 3 hour session, evening 3 hour session.
Right.
So we divide the activity. So during hot climate in the summer season, like the main program, like the gait training and the standing part, we can take prior sometime. Okay, so some of the basic exercise like a strengthening they have to do prior before we start with the exercise. And during cold temperature, because of the muscles will become more spastic, it's very difficult for them to cope up. So accordingly, we have to manage with the other like icing. With the hot climate, we give the icing also other things.
Okay. Okay.
So like example, morning they do basic exercise, so evening they only do the walking part. So we have to change according to the patients and how his or her capabilities. Is he or she can do independently without our absence, or they need more concentration in our presence?
Okay. And a few participants wanted to know, like, how much exercise you do per day with the patient, and like, how long does it take for them to recover to an independent level in the society?
So depend on the independent level. So example with the paraplegic, depending on the level of injury, it is a complete injury. So the prognosis should be very clear cut. It should not like the wrong hopes to the patient. So we have to explain to the patient also and caretaker, not in the initial time, slowly during our assessment, how the patient is progress. We have to tell them, because the wrong hopes giving the wrong thought also, and they will undergo depression. So make him to the wheelchair bound and do other activity depending upon their interest. With the future we have to plan. So with this we have to tell everything. So initially like exercise will be like 1 hour, then slowly progress to 2 hours, then 3 hours. So morning evening it comes around 5 to 6 hours. Yes, with the
Okay.
proper rehabilitation.
Mhm. Okay. Okay. Thank you, Dr. Snehal. It was very
Thank you
wonderful to
so much.
have you with us. I don't think there are much questions because we have been doing spinal cord injury since 2 days. But if there is something left, I request you to please go on the chat on YouTube and reply to the participants if there is something meaningful. Thank you.
Sure sir, sure sir.
Thank you.
Thank you,
Thank you
Dr.
sir.
Snehal, for being with us on this platform.
Thank you sir.
So with this note, I would, on behalf of Rehabilitation Sciences Group, I would thank you, and thanks to all the participants too, to being with us. Thank you so much.
Thank you, sir. If any questions, you can, I will drop the answers also. No
Yeah,
problem.
sure.
Thank you, Sagun sir. Thank you, Dharam sir.